welcome everyone. I'm Mariangela Pellegrini. I work for the ERN-EuroBloodNet, and I'm really pleased to welcome all of you on behalf of the ERN and also on behalf of the European Haemophilia Consortium, who indeed co-organized and planned this program with the ERN. So this is a conjoint program. And this educational training is created also in partnership with EURORDIS-Rare Diseases Europe, and it's supported by members of a scientific committee that consists of Professor Sophie Susen from the CHU de Lille in France, Professor Jeroen Eikenboom from the Leiden University Medical Center in Netherlands, and Professor Flora Peyvandi from Ospedale Maggiore Policlinico, Milan in Italy. And indeed, with this program that consists of a cycle of different sessions dedicated to Willebrand disease, we really wanted to tackle this clinical domain. And this has been a project really patient-centered. And for introducing that, I pass the floor to my colleague, Daria Camilli, so she can explain to you the important role that European Haemophilia Consortium have in this program.
Thank you so much. Thank you, Mariangela. My name is Daria. I'm Education and Communication Manager at the European Haemophilia Consortium. And before I make a short introduction into the European Haemophilia Consortium, I would like to thank on behalf of the organization, the ERN-EuroBloodNet, for this true cooperation between the organizations and for the opportunity to create together such a platform and such a unique project like this one to educate both clinicians and patients. So a few words about the EHC, which stands for European Haemophilia Consortium. It's an international non-profit organization representing 47 national patients organizations for people with rare bleeding disorders from 27 member states of the European Union and beyond. The EHC represents approximately 120,000 people diagnosed with a rare bleeding condition such as hemophilia, von Willebrand disease, and other extremely rare bleeding disorders across Europe. Among those, VWD is the most common bleeding disorder, affecting up to 1% of the general population. However, it is often neglected and overshadowed by hemophilia. So this program that we created together aims to distinguish von Willebrand disease from hemophilia and focuses on the particularities of this bleeding disorder. Within the framework of this program, we discuss very topical areas related to VWD among patients and healthcare professionals, and we give visibility to the challenges of those living with this condition, including quality of life, access to treatment and care, medical services available in Europe, diagnosis and treatment options, and the overall patient journey through life. So this webinar is part of this educational program, as Mariangela already mentioned. And today's topic is Women Bleed Too. We will discuss menstruation, managing periods, impact on life, sex, and etc. And I believe that the topic speaks for itself. It's very huge topic, actually, and that's why also for the first time in this program we have 4 speakers. But before we move to introduction, I give the floor back to Mariangela to talk a bit more about the benefits that medical students can get from this program and also about the home rules.
Thank you so much, Daria. Indeed, I will share with you some home rules before starting. Including also good news like the accreditation that I was mentioning. So before the rules. So this session is recorded, as you can see. So if you don't feel comfortable, please switch off your camera or change your name in the platform. And also, this is recorded because all the videos will be implemented in the learning environment of both organizations we mentioned. And so we think this is also a crucial way for spreading the awareness and the knowledge we would like to share and make patients, organization, and professional also aware. So the accreditation, indeed, this program is accredited by the European Body of Accreditation in Hematology. Each session means one continuing medical education point. For requesting them, it's a very easy process. We will track your presence, so please use your real name and surname in the platform so we can track you. And then at the end of the program, we will count in how many sessions you were, and we will guide you through the formal request of the accreditation, of course. So it will be very easy. But it is important for getting the credits also to answer to a survey you will receive after this webinar and after each webinar. It's very quick. It takes only 1 minute for answering. It's a satisfaction quiz, so it will be very easy for you to answer. So let's become this session that we really look forward it. As Daria was mentioning, today we have the chance of have 4 speakers with us because it reflects the complexity also of the topic and the importance of the topic we are going to tackle. So I would be very glad to introduce to you for this session, I'm sorry, the Dr. Beatrice Nolan, who is consultant hematologist at the Comprehensive Care Center for Children in Ireland, in Dublin. And also, I'm glad to introduce to you Dr. Karin van Galen, sorry for the pronunciation, that is also an hematologist from the University Medical Center in Utrecht in Netherlands. So Daria, do you want to introduce the other 2 speakers?
Absolutely. I'm thrilled to introduce to you Natalie Lawson because it's actually the first webinar in our series when we have a nurse perspective. So Natalie is a hematology specialist nurse from the Birmingham Children's Hospital. And in addition to her occupation, she also serves as a trustee for the UK Haemophilia Society. And of course, we have a patient perspective represented today by Cathy Verbraeken. I tried to pronounce the Dutch R. I hope I managed. She's the member of the EHC Willebrand Disease Committee, and also she's a chairwoman of the Dutch Haemophilia Society Willebrand Disease Committee, and a patient herself, of course. And with this, I give the floor to Cathy, but just one more second to mention that we will accept Q&A after the presentations. So please either drop them in the chat or raise your hand afterwards, after all 4 speakers finish their speech. And with this, Cathy, the floor is yours.
Thank you, Daria. Thank you for the introduction, and you pronounced it really well. Now, I'm Cathy from the Netherlands. I'm married, and I'm also a mom of 2 daughters. And in our family of 4, we all have a type of von Willebrand disease. My husband and eldest daughter are both having type 1, and my youngest daughter and I are having type 2N. Our youngest daughter was diagnosed at the age of 3 with von Willebrand disease after she suffered from multiple bleedings when she had her tonsils removed. Because she was diagnosed with type 2N, our entire family was tested on DNA based. And after the diagnosis, we were left with many, many questions. Back then, we were told that it was von Willebrand disease, and that is not really that exciting. And if you have a good treatment plan, you will learn about it by time. I will talk about 2 experiences in our family. First, one of my own and the other one of my daughters. When I was 30, I had my uterus removed. I had periods for more than 3 weeks every month for years. So I didn't have a social life. Doing shopping, picking up the children from school, or simple having lunch with a friend was often not an option for me. At some point, my health got so worse, and my iron was so low that I needed a 3 monthly base iron infusions to keep everything normal. I was treated by a gynecologist at the regular hospital, where she tried almost every option to get my periods under control, but it still was not working. And my quality of life as a mother was, worthless. Of 2 young children, I cannot do anything with them or for them. So together with the gynecologist and a psychologist, we decided to have my uterus removed, despite the wish that we had for a 3rd child. So that was really sad, but at some point it was also not working to go on like this. The plan was made with the hematologist of my treatment center for taking out my uterus. And after that removal, my quality of life has changed a lot. I was myself again, I could work again, I could be there for my children, do things with my children, and life was fun again. But when I look back now, and when I now know what options there are, I don't understand why bleeding as a cause was never examined in combination with my von Willebrand diagnosis. And maybe there were still other options available for me for a treatment instead of removing the uterus. So that's one thing. And the other thing that I wanted to speak about is the menstruation of my youngest daughter with the type 2N diagnosis. She started menstruating at the age of 9, and that's very young. But luckily we were at home when it starts, because we were completely unprepared for what was to come. And this was a really traumatic event, both for me as for her. The months after, we monitored her menstruation. We filled in many forms, and I think it took a year to, turned out that she had a period every month around 12 days. And wasn't able to go to school the first 3 to 4 days because of the heavy bleedings. And after all that monitoring, the first solution that was offered to her was the contraceptive pill. And as a mother of a young 9-year-old girl, maybe she was 10 at that time, we absolutely did not want her to take hormones as a treatment. But we didn't know there were other options. So through a fellow sufferer, I discovered that prophylaxis could be a possibility. Discussing this in the consultation room at that time was not very easy, but luckily our doctor was willing to think along and received a trial period of prophylaxis, which quickly turned out for her to be the solution. Her period went from 12 days till, I think, 8 to 9 days. And she was often able to go to school for the entire period. She can stay over with friends and going to the gym class. The only downside of it was that we had to go to the hospital 4 times for treatment during her period. And we are living in the Netherlands. It's not a very big country, but it takes an hour to get to the treatment center, stay there for the treatment, and go back. So she was missing a lot of school. But again, we were very lucky, because our doctor decided that I, as a mother, could learn to give the youngest daughter her medication. And you can imagine that it was changing her life, but also our life as a family because of this opportunity. She was able to go to school. She was able to go exercise. She can stay with friends. And it was really, she still have periods for 8 to 9 days, and that's still too long. And I think it can be better at this time, but it changed everything for her. It changed her whole world. And I know that prophylaxis is a much discussed topic lately, especially when it comes to female-specific bleedings. I also know that it cannot always be used like that, and that it needs to be looked at carefully. But from my own experience, I dare to say that this could also positively change many women's lives. And I hope that prophylaxis in the future can be more often an option. for many, many women, because it has changed our lives so much. And I think I could talk many, many more about many, many more topics. But yeah, I think this was it for me to share today with you. So thank you for listening.
Thank you very much. So passing the floor to the next speaker, Natalie, I will share the screen so you can follow also the presentation. Here it goes.
So thank you once again for the introduction, and I'm going to sort of talk about how we manage girls with their periods in Birmingham. So next slide, please. So just a bit of background, that's me with one of my young men who has haemophilia. He's now 6'2" and doing his adult nurse training. So we obviously inspired him to follow in our footsteps. A bit of context, we're in that lovely blue building on the left, but the majority of our hospital is in an old Victorian building as shown on the right. So we're very lucky to be in a modern building. Next slide, please. So I went right back and you know, we're a very multicultural city in Birmingham. So I look after children from all ethnic backgrounds, and there are lots of different beliefs around periods. And I found some really interesting stories. In ancient Greece and Rome, if a lady was on her period and took her clothes off, she could scare away hailstorms, lightning and whirlwinds, which seems like a useful talent to have here in the Midlands at the moment. Looking deeper into more recent views, in Hinduism, that this seemed to be the most controversial culture that I found, that some Hindus believe that having your first period is really positive and it's celebrated with presents, but some more conservative Hindus, menstruating women are asked to stay away from domestic activity. They're isolated in a separate room or a separate building, and there is no physical intimacy during their period. Islamic women are not allowed to pray or fast during Ramadan when menstruating. And one of my colleagues that works with us is Muslim, and she remembered as a young child, as a teenager, when she had her period during Ramadan, her mum told her to go and eat away from the boys, her brothers, so they didn't know she was on her period, because you didn't talk about it and the men did not need to know about these things. And Alia was only in her 30s. So, you know, the beliefs like that are still very valid. In Sri Lanka, it's celebrated quite often with a big girl party, as it marks that there is a young woman in the family now ready for marriage. And I think it's, you know, an old-fashioned tradition from when people did get married at a much younger age because life expectancy was less. But it just shows that across all the cultures that we deal with in a multicultural city, there are completely contrasting beliefs about your period and what it can mean for you. So next slide, please. Let me go on to terminology. And I remember growing up, it was like painters and decorators are in. You never said you were on your period. And there were so many different codes that girls had. And I looked up some of the, you know, common terminologies in other countries. And I think the French one of Ketchup Week is my favorite. But, you know, even, you know, people can't say I'm on my period. It just seems that there's still such a negative connotation about bleeding and having a period. So never mind cultural beliefs, and then you've got different terminology. Where do you start with what to use? And, you know, in my day, there was a house brick or a house brick. Now there are so many more products for the girls to choose from. And it you know, while it's really good, it opens up far more choices. And the period underwear sound amazing. But what I don't know, because I've not had chance to discover, is how much do they hold? Do they cope with clots? Because while they look amazing and the concept is great, if you've got heavy menstrual bleeding, that's no good. And if you need to change your pants at school, that's a far more bigger effort to completely change a pair of pants than it is to change a sanitary towel. And if you've then got soiled pants, what do you do with them for the rest of the day? you can't easily carry those around in your rucksack. So while there is a lot more variety for young girls and women today, you know, I don't think everything is viable for every scenario. Next slide, please. So when do we start managing the first period? And, you know, my colleagues and I believe that we start preparing the parents and the young girls way before it's likely to start. I talked to some friends who are teachers, and in the UK, they start talking to children in year 4, which is the school year aged 8 to 9 years. And while that seems remarkably young, as Cathy said, her daughter was 9 when she started her periods. So while it seems scarily young, it's the reality. And from what I can gather, it's very basic information. And as the children go into the next couple of years academically, the information gets more detailed. And I think year 6, when they're 10 and 11, they get separate boy-girl chats where they go into a lot more information about what a period is and things like that. But, you know, if a 9-year-old's only had basic information at school and the family aren't very communicative, it's a huge shock. So, you know, we like to start talking to our girls when they're this sort of age. And sometimes the moms are more anxious than the girls. And the girls have got no idea what's coming, bless them. But mum, if she's got von Willebrand's, knows what heavy periods are like. And, you know, you quite often talk to mums and it's like, oh, we all have heavy periods in our family. And it's, yes, that is normal for you, but that is not a normal thing to have to put up with and live with. So it's, you know, managing parents' anxieties and then also making sure that the heavy bleeding that is well known within the family, that we still manage it appropriately for that young lady and not just let mum think, well, this is how it has to be because this is how it was for me. And, you know, as I say, we do like to talk to the girls quite young, but, you know, some cultures are not so keen on open communication. And so we have to respect what the family's beliefs and feelings are around this. So, you know, while we like to, we would never go against a parent's wishes, and we would perhaps try and persuade them that, you know, okay, if you don't want to talk to your daughter about her period, then we are more than happy to talk to her with you present. So, you know, the young lady's still getting the information she needs. And, you know, generally we've looked after these children from tiny and they know us well. So it's not like they're talking to a stranger or a school nurse that they've never met before. And, you know, I'd say to any parent out there who's worried about their daughter starting their periods, utilise your nurses. You know, we're a fantastic resource. We've got lots of knowledge and experience of managing children as they start their periods. So if you've got any questions that you want to answered before you even think about your daughter being in that position, utilise the nurses that look after your children. Next slide, please. So lots of different treatment options, and if I'm honest, we use a combination of all of them. So tranexamic acid, you know, don't underestimate how effective it can be. It's not the be all and end all by any means, but, you know, we say to the girls, please take your TXA, because if you don't, we don't know if it's working for you. You know, and I know it can upset tummies and it's a pain to take it 3 times a day, but it can be really, really helpful. We have a cohort of teenagers who hate taking iron, and I've had to take iron, and I know it's not a fun medication to take. So we'll compromise with, well, just take it once a day, but take it every day. If 3 times a day is too much, please at least try and take it once, so they're getting some iron. But, you know, I've got teenagers who refuse to take it, then come to me moaning they're tired with their hemoglobin of 80. And I can't do any more than ask you to take your iron. So, you know, trying to get the teenagers to take medication is a battle. I've got a teenage son and I know how challenging teenagers can be. We use hormonal control. We use both progesterone only and the combined pill. And, you know, we don't go straight for the progesterone only. It's not something we like to use long term, but it is a useful tool to give the girls a break. If they're really struggling, for example, during their GCSEs and their exams, if, you know, they're worried they're going to have breakthrough bleeding or have a bad period that's going to interfere with their exams, we'll put them on northisterone for a period of time to get them through any significant life events. We use the combined pill in various ways. We will sometimes give the girls 21 days on, 7 days off. And in those 7 days, they have a bleed. And sometimes that bleed can be enough to be managed with just tranexamic acid. And sometimes it can be managed with clotting factor alongside that. Some of the girls take the pill back to back, so they just take it constantly for a 6-month period. Then during the school holidays, they'll have a timed period. So they'll come off the pill, have a period while they're at home. It might be bad, but we can manage it with clotting factor if they need it. And then they go back on the pill and have another 6 months back to back. So that's one of the ways that we do use the contraceptive pill to support the girls. We do use clotting factor concentrate. We had one young lady from a Muslim background who did not want to take hormonal control. So she learned at the age of 12 to self-infuse clotting factor concentrate on day 1 and day 3, and if needed on day 5 of her period. So, you know, we will use clotting factor concentrate on the girls if that's what they prefer. And we would either teach parent or the young lady, depending on their age. One thing I forgot to put in there actually is we do sometimes use DDAVP for the girls. If we know that it works and they've had a trial to check that their levels rise, then we will use DDAVP and again teach them to self-administer on day 1 and day 3 of their period. We do discuss the use of Mirena coils. And, you know, it's a difficult one because these are young ladies that we hope are not sexually active. And it's a big thought to have something inserted vaginally. So we have used Mirena coils, and in the under 16s, they're put in under general anaesthetic. So the young ladies don't have to be awake. It's all done with them under anaesthetic. I've got a young lady at the moment who's really struggling with her periods. And again, a Muslim child, and she would like to consider the coil because she knows it would be put in under anaesthetic as a child, but she's petrified about having it removed as a young adult while she's awake. So, you know, this has just happened today, and I've contacted my adult colleagues who said, no, we could do it under general anaesthetic when she's 18, 19, no problem. So, you know, it's reassuring the young girls that if that is an option they consider, they don't necessarily have to be awake as a young adult to have it replaced. We have got to the point in some kids that they've needed a blood transfusion or intravenous iron infusions. And there's pros and cons to both. And if it got to that point, we would talk through with the family which one they preferred. And we have done both for our young ladies at various points. And, you know, again, it would be a decision made with the family about which one of those they would prefer. And then there are lots of things that you can do to help yourself that are not medical. So next slide, please. So none of these are going to make your periods lighter, but you know, I'm a great believer if you can help yourself and have a positive mental attitude, it can, you know, help to make things a little easier. So just gentle exercise. Swimming's a difficult one because if you've got heavy menstrual bleeding, then going into the swimming pool is not going to be the most ideal thing. But, you know, if it can be done, it's good. Keeping a diary and monitoring your periods, because sometimes it's hard to look back and think what they were like 6 months ago when you come to clinic. So keeping a record is quite good, and it stops the embarrassing scenario of the male doctor saying, so have your periods been the last 6 months? You can just hand over the period diary and just die a quiet death in the corner of the room. Being a healthy weight, eating iron-rich foods. But again, I'm talking about teenagers, so that is a different battle in itself. Pain medicines, unfortunately, you ladies are limited to just paracetamol because you can't have the non-steroidals. But paracetamol can be helpful. And if that's not controlling your pain, please talk to your centre because there may be other options that they can look at for you. You know, a soak in the bath and a hot water bottle is just good therapy for anybody. But, you know, a hot water bottle can definitely help. And, you know, be kind to yourself and rest. You know, for somebody without a bleeding disorder, you can be tired when you have your period. So you know, why would it be any different for you guys? So, you know, rest and be kind to yourself. And I keep drumming it in, take your iron medication, because it really can make a difference. Next slide, please. So ongoing support, we do direct them to the Know Your Flow website and talk about the 721 rule, where if you're changing your pads more than 7 times a day, more than 2 hours between change, less than 2 hours between change, and passing clots the size of a €1 coin, you know, we direct them to that. And those are the kind of things we would ask them to contact us about. We do use this bleeding disorder diary quite a lot, again, so that the girls can fill it in, bring it to clinic, and there's less embarrassing questions they've got to answer. We've got 2 female and 1 male consultant, and our male consultant is golden with the girls. He's absolutely brilliant, but it's still a man asking you about your periods. So the bleeding disorders diary just helps that embarrassment to a degree. Again, take your iron. If they start periods in primary school, so under the age of the 11 in the UK, it's generally one teacher that looks after them for the whole of the school day. So that's fairly easy negotiation for that one teacher to understand what's going on. But when they go to secondary school, it's a different ball game, and they might only have that teacher once a fortnight. So we ask for what we call a toilet pass. So it's just a pass that says, I need to leave the classroom to go to the toilet. And it means that if a young lady's changed her pad at break time, goes into class, and half an hour later she feels like she's flooding, she can leave the classroom without any explanation. And, you know, I always say to my girls, if your science teacher is a really old man and he asks you why, you just tell him, I have a toilet pass, go and talk to Natalie. And I will then explain to the teachers why you have walked out of class. And we ask that they can have access to probably a disabled toilet where nobody else is around, that has a sink in the toilet, so that if they have flooded, they can go somewhere private to clean up, and they have somewhere that's not their locker to store a change of clothes. So if it has gone through to their uniform, they can get changed. So that's the kind of liaison I do with the secondary schools. And what I say to the girls is, you know, your mum's not going to check every pad you throw away. She doesn't need to do that. But I need you to be honest with her about how much blood you're using. We had one young lady who kept saying to her mum, no, it's all right. It's not bad. It's not bad. And she came with a hemoglobin of 6 and had to be transfused because she'd lied to her mum. So we always say to the girls, please don't, you know, let your mum know how bad it is. And if the girls are on the contraceptive pill and they come to me saying, oh, I've got breakthrough bleeding, have you missed any? Oh, no. Again, if I don't know the truth, I can't manage it correctly. And how I would manage breakthrough bleeding from missing a pill versus breakthrough bleeding when you haven't is different. So, you know, I always say to the girls, no one's going to be cross if you've missed a tablet, but we can't help you if we don't know what's gone on. So next slide, please. So gynae support, we have found it varies from centre to centre in the UK. At Birmingham Children's, our girls wait 18 months or more to see our gynaecologist colleagues. If we refer them to the local adult hospital, it can be a bit quicker. And, you know, we are experts in bleeding, but we've got very little knowledge about the specialist options and the various pills and regimes that can be used to manage heavy menstrual bleeding. So we can start the girls on something, but what we don't have is the knowledge of different tablets, side effects, benefits, profile and stuff like that. That's where our gynecology colleagues come in. And our long-term aim is to build better links with our gynae colleagues. And our advanced nurse practitioner, her aim next year is to start clinics for the girls. And when they're sort of 8 or 9, they start tapping into Katie's clinics, and they would have open access to those clinics if they were having problems with their periods and needed support. And then they're seeing somebody they know, and they're seeing a woman. So next slide, please. Transition, we theoretically start transition at 11, but it's a fluid process. Our patients transition after their 16th birthday. Transition is scary, generally more for the mums. I had a mum yesterday, but I can't go in with him when he sees the doctors. I'm like, yes, you can. They're fine about that. I think there's a perception that, you know, as soon as they go to the adult hospital, mum's not allowed there, and that's not true. So, you know, we try and support them with a visit over to the adult centre before they have an appointment, so they know where to go, where to park, where to find the nurses, and they've met everybody before they go to clinic there. And for our girls with heavy menstrual bleeding, actually, we see transition as a really positive thing, because our adult colleagues have got far more experience of managing heavy menstrual bleeding, and they have much better links with gynecology and obstetrics than we will ever do in paediatrics. So, you know, actually going over gives them far better access to management than they can get within the paediatric setting. So next slide, I think that might be it. Yeah, and those were just my references. So thank you very much.
Actually, that's it, yeah. So my name is Beatrice Nolan. I'm a consultant hematologist working in the Children's Hospital in Dublin. And in terms of what you were saying there, Natalie, can everybody hear me okay? Yeah, we have just our advanced nurse practitioner is just setting up clinics for girls with heavy menstrual bleeding as well, who have bleeding disorders. And we're setting up, we have set up an MDT with the local adolescent gynecology service and the adult bleeding disorder service. So we've just this year set up a joint bleeding disorder gynae MDT. But anyway, I wanted to talk about, before talking about menstrual health and von Willebrand disease, I just wanted to talk briefly about menstrual health in globally. So this is the most recent report from the WHO about menstrual health and education worldwide. And if you look there, you can see that globally, and that includes the first world, about 2 out of 5 schools provide menstrual health education. And only about 1 in 3 schools have bins for menstrual waste in girls' toilets. But that varies depending on the part of the globe you're in. So, for instance, in Central and Southern Asia, only 1 in 3 primary schools will give menstrual education, whereas in Sub-Saharan Africa, 1 in 8. And you can see then the rate of bins being provided for menstrual products in the least developed countries in the world. Less than 1 in 5 schools provide bins for menstrual waste. The report said that stigma related to menstruation remains widespread, with adolescents often feeling ashamed or unable to openly discuss the topic, and this shame can affect their mental health and school attendance. Next slide, please. This is a report. It's a report from the UK, and the reason I picked it is because the most recent one I could find, and it's from researchers in Bristol, and it was looking at 21-year-old girls and their experience of menstrual health education in school. And this is reflected, I think, in all first world countries, really. The lessons focused on the biological content. So your uterus, your fallopian tubes, your vagina, rather than what happens in the and how that might actually affect you. But there was actually lack of practical information needed to help the students manage menstruation and menstrual health. None of the participants were taught about menstrual health conditions. So, and 3.2% said they learnt about abnormal symptoms. And some girls or young women, because they were 21-year-olds when this was done, reported long-term impacts because they didn't know what was abnormal. Next slide, please. So overall, they left school feeling lacking basic knowledge and ill-equipped to deal with menstrual difficulties. In extreme cases, now some were so unprepared that when they started their periods, they thought they might be dying. A lot of teenagers and young women rely on social media for education about menstrual health. and there was a similar study from Australia which suggested that teachers, particularly male teachers, are embarrassed to talk about menstrual health because, you know, if you're talking to a primary school class about menstruation, you might be talking about sex, you might be talking about genitalia, and they feel uncomfortable doing that. Next slide, please. So no more than Natalie said, it's important to start education before menstruation, before, you know, you start talking to the child and the parents before menstruation starts. Girls will begin to menstruate about 2 to 3 years after breast development, and that menstruation is a normal part of development. And there should be advice on using period products and what is considered normal menstrual flow. So we try to do that in our clinics, so that we talk to girls with bleeding disorders about the first period, before the first period happens. Next slide, please. So this is the International Federation of Obstetrics and Gynecology definition of abnormal uterine bleeding. So no more than all the words for period around the world, there are a load of medical terms for abnormal or normal menstruation. So this is an attempt to get rid of all those words and try and have some kind of consensus about what is meant by abnormal uterine bleeding. So abnormal uterine bleeding is a collection of symptoms that include intermenstrual bleeding, that's bleeding between your periods, abnormalities in period duration, cycle length and regularity. So chronic abnormal uterine bleeding is abnormal uterine bleeding that's been present for the majority of the past 6 months. Acute abnormal uterine bleeding is an episode of heavy bleeding that is of sufficient quantity to require immediate intervention to prevent further blood loss. And that can happen. We see sometimes girls being admitted with what we call acute menorrhagia, or I shouldn't say menorrhagia now, acute abnormal uterine bleeding. So girls come in with, you know, with their first period, often because of a bleeding disorder, and they're just having torrential periods, and they need to be hospitalized for intervention to stop that bleeding. But acute abnormal uterine bleeding can occur on chronic or as an independent episode. So next slide, please. So there were 2 classification systems. So the system 1 defines the bleeding pattern, and system 2 tries to look at the causes of the abnormal bleeding. Next slide, please. So this is the system 1. This is looking at the bleeding pattern. So looking at frequency, duration. So how often is the menstrual bleed happening? How long is it lasting? Are the periods regular or irregular? And then the flow volume. And this is determined by the patient. There are loads of different ways to do this, but it's determined by the patient. And then I'm not going to talk about the intramenstrual bleeding or the unscheduled bleeding. That sounds a bit odd, unscheduled bleeding. But just talking about what's normal and abnormal in menstruation. So next slide, please. So physiological menstruation, this is what is supposed to happen. It doesn't always, but so this is what is supposed to happen. You should have a period every 24 to 38 days. It should last less than 8 days. And the longest to the shortest cycle variation should be 7 to 9 days. And the volume of typical menstrual bleeding should not interfere with your quality of life. So I'm going to go on to the next slide, please. So this is what's called a pictorial blood assessment chart, or a PBAC. So this is one of the ways used to quantify menstrual blood loss, and it's self-reported. So you score per number of pads or tampons used. So each day there, day 1, you get a particular score for a lightly soiled pad or tampon, a different score. So you mark in the number of pads per day, looking at that pattern. And that's how it only goes to day 8. But anyway, so that's one of the ways of recording or trying to quantify menstrual blood loss. Next slide, please. So there's loads of different ways to try and quantify menstrual blood loss. And as I always say to people, if there's loads of different ways, it means none of them is really any good. So the old method was women used to have to collect all their soiled sanitary products, and then they would measure the amount of blood on them. And that's still used for women participating in clinical trials, for instance. So you bring along all your soiled sanitary products and somebody measures the amount of blood in them. But that's actually quite a difficult thing to do, and nobody would like to think of a pile of used tampons in the corner of any room in the house. So impact on quality of life, because impact on quality of life is one of the definitions for abnormal uterine bleeding. The PBAC I just mentioned, and then there's another one called a menstrual pictogram, but I actually didn't put in a picture. And it's basically the same as the, it's a variation on the PBAC. So next slide, please. So heavy menstrual bleeding, based on the days of gathering up all the soiled sanitary towels in a black plastic bag and bringing them into the hospital, was defined as a loss of more than 80 mils of blood per cycle. But again, that's not done anymore outside, clinical trial settings, really. And even then, it's a very difficult thing to ask women to do. So again, it's excessive menstrual blood loss, which interferes with physical, social, emotional, and/or material quality of life. Next slide, please. So this is from 2021, and this is the proposed definition. It kind of went along with the von Willebrand disease guidelines from that time. So menstrual bleeding meeting any of the following criteria: lasting more than 7 to 8 days, changing more frequently than every 2 hours on multiple days, using more than one product at a time. We have a girl who wears incontinence pads, who used to wear incontinence pads to bed. Requires changing sanitary protection during the night, associated with repeat passing of blood clots. It's funny, you have to explain to girl what a blood clot is. It's like you try to say like a lump of meat or a lump of liver, and nobody knows anymore what liver is because nobody eats liver anymore. So, and then a pictorial blood assessment chart score of greater than 100. And all of these are significantly more prevalent in women with von Willebrand disease compared to women in the general population. So next slide, please. So this is the 721 from knowyourflow.ie. So this is really handy to say to people, do you know what a heavy period is? And most people actually don't. So lasts for more than 7 days, if you need to change more frequently than every 2 hours, and if you need to pass clots larger than a €1 coin. I don't know what size a £1 coin is, but we say €1 coin. Next slide, please. So using the PBAC method, a score of over 100 is found, if you use a score of over 100 for heavy menstrual bleeding, 74% of women with von Willebrand disease were reported to have heavy menstrual bleeding. If you use a score of 185, 71% of women with von Willebrand disease were reported to have heavy menstrual bleeding. Next slide, please. So again, this is a report from the UK, the impact of von Willebrand disease on women's health outcomes. And this is a report from 2022. And the grey line is women without von Willebrand disease. The black line is women with von Willebrand disease. And if you go up, you can see that's the percentage of women with heavy menstrual bleeding. And as you go out to your right, that's the number of years from entry. And as you can see that there is a significant difference in the amount of heavy menstrual bleeding, in the percentage or the proportion of patients with heavy menstrual bleeding in the von Willebrand disease patients versus the patients without von Willebrand disease. Next slide, please. So this is part 2 of the FIGO classification. So the part 1 was looking at duration, regularity, flow. This is looking at causes, because women with von Willebrand disease can have other reasons as well as the von Willebrand disease for having heavy menstrual bleeding. And, you know, it's important to know that not everything can be attributed to von Willebrand disease, and no more than other women. Women with von Willebrand disease can have other issues, other gynecological issues as well. So it's called the PAM-COIN classification. So this is the causes. So sort of things like structural or abnormalities, you know, physical abnormalities, things like a polyp, adenomyosis, which is where the endometrium kind of goes into the body of the uterus and bleeds from there. Leiomyomas or fibroids, malignancy and hyperplasia. So those will all occur in women with von Willebrand disease. So you can't assume that heavy bleeding is due to the bleeding disorder only. If, you know, so there, it doesn't, in older women, and it's more likely to be, you know, these are more likely to occur as women get older. We wouldn't tend to see these in children or adolescents with von Willebrand disease. And then the other side of the causes is called COIN. So coagulopathy, your von Willebrand disease fits in there. Ovulatory dysfunction, so problems with ovulation. You're supposed to ovulate with every cycle. Endometrial, that's the lining of the uterus. Iatrogenic means usually caused by medical things, and not otherwise classified. Not otherwise classified is always a great one for causes when you're looking at exams. Anyway, so you can't assume that everything is due to a bleeding disorder. So next slide, please. So AUBC at the top of the slide there is abnormal uterine bleeding caused by coagulopathy. So it's secondary to inherited or acquired bleeding disorders, with the most common disorder being von Willebrand disease. And then AUBO is the ovulatory disorders. So that's problems with ovulation. So if you look at the left into the red is good. So you ovulate every 24 to 38 days and you have normal menstrual, this is what's supposed to happen, normal menstrual frequency and regularity. Then if you have no ovulation on the blue side, you've got no periods. So you might have amenorrhea. And then in between, the less you ovulate, the more likely you are to have irregular periods and problems with light, well, not so much problems with light, but heavy periods. So problems with ovulation can also cause problems with heavy periods and cycle length and cycle irregularity. Next slide, please. And the reason I mentioned the ovulation thing is because when girls are starting their periods, girls or teenagers are starting their periods, a lot of the cycles are not associated with ovulation. So the most common reason for teenage girls having problems with their periods is because ovulation isn't established. But the second most common cause is bleeding disorders. So about bleeding disorders are found in approximately 1 in 5 girls who present with heavy periods. And bleeding disorders are found in about 1/3 of girls who are hospitalized for heavy periods. So the teenage girls kind of have a double whammy. They have the bleeding disorder and they're not ovulating. Next slide, please. So again, as Natalie was saying, the treatment options should be considered on their benefits, their side effects, potential risks, to allow the girl, the adolescent, the woman to make an informed choice. It's important when you're looking at treatment to decide, well, is this woman, does she want to get pregnant? Does she not want to get pregnant? You know, does she want to hold on to her uterus? Does she not want to hold on to her uterus? It depends on her age. And then you have to think about other things that might be causing the bleeding, like fibroids. You might think of other issues like pain, the type and severity of the von Willebrand disease. Next slide, please. So I'm sorry this is such a busy slide, but and I forgot to put the reference on. It's from the UK HCDO guidelines from 2022. So this is an algorithm for treating heavy menstrual bleeding in women with inherited bleeding disorders. So if you go on to the next slide, please. So this is this is what's suggested for women and teenagers who don't want to get pregnant, who are not trying to conceive. So their hormonal treatment is indicated and acceptable in this population. So what is suggested as first-line treatment is a coil. So the coil, like the Mirena coil or the other intrauterine systems, can be, a study done showed that they can be associated with a significant reduction in PBAC scores, amenorrhea, which means no periods at all, in 42% of users, improvements in hemoglobin, improvements in quality of life. But you can have bleeding over the first number of months, so you might require additional treatment directed at bleeding for the first several menstrual cycles after the coil is inserted. The problems there are irregular bleeding and spotting during the first year of use, progestogenic side effects, which would be maybe breast tenderness or dizziness, fainting, nausea. Expulsion means they just come out, and malposition, they're in the wrong position. Next slide, please. Oh, sorry, if you don't mind going back again, sorry. Then the next line treatment would be, if somebody didn't want to go for the coil, would be the combined oral contraceptive pill. And if you go on to the next slide, please, there. So this would be useful to be considered, again, in women who don't want to conceive, if they don't like the idea of the coil, or the coil is not acceptable, the intrauterine system is not acceptable, and the rate of control of heavy menstrual bleeding is reported to be between 24, so 1 in 4 women, to 90%. That's quite a wide range. You can use it, you can use it for 21 days and have a bleed, or you can use it back to back. You generally get about 3 months going back to back. After that, you'll have breakthrough bleeds. So about 3 months is as much as you're going to get. But that means instead of having 12 periods a year, you might have 4 periods a year. Or, as you know, you can arrange your back to back around exams or holidays. So a lot of girls, teenage girls, will go for back to back treatment. So if the first line hormonal treatment fails, the suggestion is to add tranexamic acid. And then if the above treatment fails, consider a trial of desmopressin, so DDAVP or other hormone options. Now, the problem with DDAVP for us in Ireland, we don't have access to subcutaneous DDAVP. We only have intravenous DDAVP. And we don't have the nasal spray at the moment because it's been withdrawn. We don't have access to that at the moment. So desmopressin really isn't an option for us to use or to advise in Ireland at the moment. Next slide, please. So if someone doesn't want to use hormonal treatment for whatever reason, then the options are tranexamic. The main options would be tranexamic acid and the intranasal desmopressin. And they were both in sort of crossover studies where you sort of start the desmopressin and change to tranexamic acid, or start tranexamic acid and change to desmopressin. The tranexamic acid actually came out better than the intranasal or the nasal desmopressin. And this was 2022, concomitant use, so using both at the same time, the desmopressin spray with tranexamic acid. Now, our problem is we can't access the nasal spray at the moment. I don't think it's back on the market yet, as far as I know. It was withdrawn in 2 or 3 years ago. So on to the next slide, please. So, so you could consider factor concentrate as necessary, and then back if that if all else fails, then you're on to surgical and radiological therapeutic options. So surgical options would include hysterectomy, removing the uterus, things like endometrial ablation, where you destroy basically the lining of the uterus. And these options are for women who have maybe completed their family or don't want to have further pregnancies. Next slide. So back to the adolescents. Again, the use of the coil is recommended as first line for adolescents, but we would find that our gynecology colleagues would be reluctant to put in a coil in a girl under the age of 16, although there's no reason 16 is any better than 14 or 15. Most girls will have it inserted under general anesthetic. And then again, the use of the pill has been reported to be effective in controlling heavy menstrual bleeding in adolescent girls with all types of von Willebrand disease. Next slide, please. This is a recent enough study, 2023. This is single treatments. So, a lot of the time you end up combining treatments, but this was a review of single treatments for heavy menstrual bleeding in women with von Willebrand disease and heavy menstrual bleeding. And you can see that the best, so the combined, on the left is the treatment option, and on the right is the patient satisfaction, and then just back a bit to the left, the number of subjects who achieved control. And you can see that combined contraceptive pill in this tertiary centre, a patient satisfaction rate of 36%, and out of 66 subjects, 17 achieved control, which is probably about a quarter. The vaginal ring, nobody was happy with, and nobody achieved control. Progesterone-only pill, it has its uses, 10% were satisfied. 1 out of 66 achieved control. Tranexamic acid, you can see there 23% were satisfied, and 11 out of 66 achieved control. Now this is a single use, this isn't combined use. The best outcome was with the intrauterine system, which is some variety of coil. LIUS is intrauterine system, and 66% were satisfied. That's only 2/3 of women satisfied with a coil, and about half achieved control. And this is in a tertiary referral centre. And then DDAVP, desmopressin, 25% happy. So if I wouldn't go back. If I was that happy with a coffee shop, I wouldn't go back, So none of these options as single agents were particularly effective, and this is only last year. So it just shows you that it can be difficult. It can be very difficult to get on top of the heavy menstrual bleeding in von Willebrand disease. But this is not first line, sort of single therapies. So in a lot of cases, we have to add in additional therapies. As you try one, then you try a different one, then you might try 2 together. So anyway, and then next slide. So I just wanted to finish to say that we're all glad that the EU is concerned that menstruation continues to. This is a report in 2022 from the European Union to the UN and other international organizations in Geneva. So the EU is concerned that menstruation continues to be surrounded by harmful gender stereotypes, stigma, and discriminatory practices in every society. The full realization of menstrual health is key for the enjoyment of all human rights. The EU underscores the right to fully participate in all spheres of life during one's menstrual cycle without any form of discrimination or being hindered by socio-economic, cultural, or religious practices and restrictions. And the EU further stresses the need for universal access to quality and affordable, comprehensive sexual and reproductive health information. So we're all waiting for that day to happen. So that's the end of my presentation. Thanks to everybody for listening.
Thank you very much. Very important that every woman has the right to have a normal menstruation at least normal functioning while menstruating. So I am Karin van Galen. I'm an adult hematologist at the Van Creveld Clinic in the University Medical Center Utrecht in the Netherlands. And I also chair the working group for women and girls with bleeding disorders from the EHAD, European Association for Haemophilia and Allied Disorders for healthcare providers. And in 2021, we've published these European Principles of Care for Women and Girls with Inherited Bleeding Disorders in order to move forward in better care and more equity also in healthcare for women and girls with bleeding disorders, which lags behind due to the male predominance, of course, of the Haemophilia disease. So what, if you haven't seen these before, please check out the paper. It was published in Haemophilia in 2021. The first principle states that there should be equitable access and quality of care for individuals with bleeding disorders, irrespective of gender. There should be timely and accurate diagnosis of bleeding disorders, which is a challenge. There should be awareness of the additional challenges faced by women and girls with bleeding disorders throughout their life, so all life stages. And there should be comprehensive care available within the hemophilia treatment centers that's family-centered and includes women and girls with bleeding disorders. There should be a dedicated obstetrician, gynecology in the team, in the multidisciplinary team. Education is very important of the women and girls with bleeding disorders, and not only the girls, but also their brothers, their parents, on the additional challenges they face with female-specific bleeding. Of course, early recognition and optimal treatment of heavy menstrual bleeding, and also important to guide women when they want to get pregnant and when they have a baby and will go into delivery with all the risks, and that there should be more research, because that's also there's so a lack of good research how to treat women and girls with bleeding disorders, but I will come to that more later also in this talk. Please, next slide. So von Willebrand disease is a bleeding disorder that's very frequently has heavy menstrual bleeding as a symptom. It's reported by over 90% of women with von Willebrand disease, and it's associated with the highest PBEC scores in compared to controls and other bleeding disorders, as you can see in this figure. Next slide, please. So about early recognition and optimal treatment, it's important that we aim to have improved quality of life, because it should not interfere with your normal daily life, the menstruation, not to a point that you miss days of school or that you miss social appointments. It's okay if you don't want to go to the swimming pool, but for other things, of course, you should have a sort of normal life. And it's important when making such a personalized treatment plan that you take into consideration whether there's fertility wishes in the future, whether there are other gynecological symptoms, what would be the underlying cause of heavy menstrual bleeding, because it's not always just the bleeding disorder. There can also be a gynecological cause like polyps that can locally be treated. Acceptance of treatment is important. It can be cultural differences and also values and expectations. Next slide. So what's really important is that there's good coordination between hematologists and the gynecologist in the team within the hemophilia treatment centers. So for those who are undiagnosed, and it has been shown time and time again that 1 in 5 women who presents to a gynecologist with heavy menstrual bleeding has an underlying bleeding disorder. But this awareness is not out yet in all gynecologists, and so I keep stating that every talk I give, that they should also think about maybe there's a bleeding disorder if they see a woman with heavy menstrual bleeding. So we make diagnostic pathways and then come to a diagnosis. Next, please. Yes, so prevent delay. There's a lot of delay before a woman presents with heavy menstrual bleeding and a diagnosis of a bleeding disorder is made. And that should get better by educating our colleagues. Next. So yes, next. So when there's a bleeding disorder diagnosis, that of course influences the management, and here we should work together too. And this is of course, when there's a bleeding disorder, a Haemophilia treatment center should be involved to make a treatment plan and treat the bleeding disorder next to possible gynecological yes, thank you, next to gynecological issues. Next slide. Yes, and when this is also important to anticipate, because if we know a girl has a bleeding disorder and she becomes at an age that's approaching her menarche, then she should know about what's normal and what's not, and when to contact the Haemophilia treatment center. And we will launch in the next coming weeks, months, menarche leaflet with information about the first menstruation for girls. That's written in a way that they can understand. It will be in English, but it can be translated by the local NMOs in every country, the national patient organizations, and then we have more materials available to prepare girls for their first menstruation. Next slide, please. So what to do when heavy menstrual bleeding occurs in Willebrand disease? There should be pathways and protocols available, so we know what to do. And when there's acute heavy menstrual bleeding, Dr. Nolan also talked about that. There will be an acute drop in hemoglobin level with hemodynamic consequences. And we, as a hematologist, have to correct coagulation, give tranexamic acid in a high dose IV, and continue orally, and also treat as a large bleed with clotting factor. And of course, platelet over 50, if there's a low platelet count, or if platelets are dysfunctional, there may be platelets needed also. And the gynecologist at their turn should provide their diagnosis and treatment, imaging if needed, hormonal treatment, and interventions. And we should make this plan together. Next slide. For chronic heavy menstrual bleeding management in Willebrand disease, I think this was discussed enough already by Dr. Nolan. But yeah, I'd like to say again that it's important to make sure that a woman, because when they are adult and a bit more senior, they might have a complete family, and then as Cathy also told to us, that it can be such a relief just to have no uterus anymore, or a definite solution for your menstrual bleeding. So that's definitely something you would like to discuss. And the DDAVP, the intranasal spray, that might be a tip for other countries, but we have the hospital pharmacy, especially in university centers, are capable of making their own medication preparations. So in the Netherlands, we have the nose spray of the DDAVP available again, but this is a hospital pharmacy preparation that's only available in the Netherlands in academic centers, but we can prescribe it again. So that's a big win. And maybe other countries can have these, can discuss this option with their own pharmacies as well. Next slide, please. So just some information from literature, which it's not too much, but what I like to share is this study for that included over 100 women and girls adolescents and girls with low von Willebrand factor and associated heavy menstrual bleeding. They were all aged below 21, They had PBEC scores over 100 and low von Willebrand factor levels, so between 30 and 50%. And they also had a bleeding phenotype with increased bleeding score. Next, please. And they were one third was treated only hormonal, with a wide variety of medications, mostly combined oral contraceptive pills, but also some had the progesterone spiral that's been mentioned before. Not many of these girls got hemostatic treatments, but if they got it, it was antifibrinolytics and desmopressin, and only 2% got von Willebrand factor concentrate, while this can be a very good solution if other options are less effective or not desirable, as Cathy told about her 9-year-old girl. And of course, also combinations were used. Next, please. However, the outcome was not so good, actually. Over half had improvement, but only 12% having menstrual bleeding resolved. And in 30%, no change occurred and 2% even worsened. Next, please. So that's a problem. Because this, yes, please. Because this gives complications, of course. Iron deficiency occurs frequently. Anemia, blood transfusions were even needed in 1 in 8 of these girls, and 10% hospitalization. So next slide, please. So we're not there yet. What to do with these girls? Well, Dr. Nolan also told us about levonorgestrel IUD spiral, and that has been used in few studies. It has been published that it's quite effective to decrease the blood loss and increase hemoglobin level, as you can see in this figure. But it needs time before it works. So time to improvement here, it's 94 plus or minus 69 days, so quite a long time before it helps. So you need to keep it in place for at least 6 months to know if it works. Next, please. Yes, and there is a concern that there were actually quite a few girls where this the spiral dropped out, and of course we have these breakthrough bleeds within the first 6 months that need extra treatment. Next, please. So what about periodic prophylaxis? So the use of clotting factor concentrate to manage the periods. Well, this is an area that needs more research. There are very few and very low quality data, while in clinical practice, we do have the experience that it can work. So this is a study that's been published by the von Willebrand Disease Prophylaxis Network. This included 52 women, but it was a retrospective study. And as you can see, the menorrhagia is purple colored, and it did decrease, as you can see, from 8% to 5% in type 1, in all types. So it does seem to work, especially in type 1, it seems to be quite effective. But it's low numbers, and it's not specifically the research question of this study. Next, please. So there has been one brave attempt to do a randomized study to find out whether von Willebrand factor concentrate would be better than tranexamic acid to treat heavy menstrual bleeding in von Willebrand disease. However, this trial stopped early due to slow recruitment, and then they did an interim analysis, and that suggested that the von Willebrand factor was not superior, but I think there was, next please, as you can see in the figure. Yes, on the previous slide, what does the percentage change reflected? I think it was that the hemoglobin level. Okay, so please, yes, move on. So here it looks like tranexamic acid and recombinant von Willebrand factor were not that von Willebrand factor was not superior. However, I think there's a problem with the design of this study, because we would normally combine these treatments, and it was only given twice, the von Willebrand factor on day 1, and tranexamic acid was continued for 5 days. So that's also a bit weird. So I think that might also be a reason why the trial stopped early, because it's not very logical intervention to do when heavy menstrual bleeding occurs. Next slide. But that's what we have. We don't have so much. And then for the women who do not have a wish to preserve their fertility anymore, this has been a systematic review on how outcome is when you do endometrial ablation. That's when you take away the lineage of the endometrial lineage of the uterus, or when you remove the uterus with or without ovaria. And what was a bit striking on this study is that even despite prophylaxis, bleeding complications still occurred. So we should be careful when women are being treated with these definite options to cure them from the heavy menstrual bleeding, that the procedure itself is also managed with good clotting factor covering. Next slide, please. And then the iron deficiency. This is also something that's very much undertreated. Actually, we don't even know the prevalence of iron deficiency and iron deficient anemia in von Willebrand disease. This is a study that's been published in 2016 already that suggests that maybe with low iron levels, that additionally affects quality of life in women with von Willebrand disease. Next slide, please. And it is important because iron supplementation does help also when there's no anemia yet. When there's not yet an anemia, the iron deficiency can give symptoms like concentration problems, which may affect your school results, and tiredness, dizziness. So it's important to treat the iron deficiency. And in this study that was conducted within healthy students, it was shown that when there was iron deficiency without anemia, the supplementation of iron made their learning and memory improve. So that their learning and memory improved when they were given iron supplementation compared to those who were not given iron supplementation in iron deficiency without anemia. Next slide, please. So there are a lot of options to treat iron, to use iron. And of course, I can understand that taking a tablet for 3 times a day, that is not very practical and feasible, and it's also poorly tolerated. Luckily, I found out that that's not needed to take your iron tablets 3 times a day. For the body to take your iron well, it's enough to use every other day or even 3 times a week 1 tablet, but you have to take it and preferably in the morning with vitamin C or juice or something, but not with liquid milk or yogurt. And then it's taken up quite good and it's tolerated much better. There are also lots of preparates available that you can find online or at your local vitamin store. And one of the interesting products is the Siderel. That's here depicted here. That's sucrosomial iron. That's taken up in another way than the classic ferrous sulfate and ferrous fumarate, and therefore it has less side effects on the gastrointestinal tract. So that could be an option too, but it's not reimbursed often, and that's the same for a lot of those vitamin shop products. But still, it's often possible to find a product that's well acceptable and that works. And if it not works orally, then we can give IV iron. Next, please. And a last subject that I'd like to discuss is the sexuality, because von Willebrand disease can affect sexuality if you have vaginal blood loss many days of the month, are tired or weak due to the anemia or iron deficiency. Contact bleeding occurs often in von Willebrand disease, while this is also a reason to visit the gynecologist to see if everything's okay. You can, of course, get bleeding from the sexual other intercourses, and your self-image or confidence may be a problem when you have a chronic illness. So these are things that especially the nurses could discuss also with patients, because this is much more of a problem than we see, because patients won't start this conversation by themselves. But they do like to talk about it, and there will be a study we did some study in von Willebrand disease in the Netherlands, and it appears to be quite a big issue, especially in menstruating women, that they do experience sexual dysfunction due to their bleeding disorder. Next, please. So high awareness is paramount to identify heavy menstrual bleeding in von Willebrand, and to identify von Willebrand disease in heavy menstrual bleeding, so both sides. We need bleeding histories, family history, laboratory testing should include blood count, but also ferritin level, because that also can give the symptoms. Use expert consultation, and we do have to work multidisciplinary with our gynecologists in the team, and joint clinics if possible. And we need more research to find the optimal strategies to improve quality of life for women and girls with bleeding disorders. Next, please. So if you'd like to learn more about this, there's a free access online webinar also from the EHED on this specific issue for inherited bleeding disorders in general, if you'd like to learn more. So thank you very much for listening, and I'll be happy to take questions.
Thank you so much, Mariangela. Before you closed already. Can we go back to presentation? There was one question about these slides, so that's why I would like to take it as the first one. So it's about Dr. Karin's presentation, the slide which was right before recombinant versus tranexamic acid.
Yes, sorry, the slide deck was not working. I will try again to share.
And we're running very much out of time, so I will check. I will try to be quick with the questions while you're looking for the slide. I will ask also Dr. Karin. You mentioned leaflet on menarche being created. Is it by EHAD or?
By EHAD together with EHC. So in our working group, there's also a representative from EHC. So yeah, it can be published on both websites. Yeah.
Yeah, I just wanted to make sure it's that one we're talking about.
Yeah.
And I will use this opportunity then to mention to all patients present at this webinar that you can always also check the resources created by the EHC, but also represented on the EHC websites. We have plenty of resources that we share, also created by other organizations. You can find them on the EHC Academy. It's academy.ehc.eu or community.ehc.eu. On the community website, we have dedicated pages to women with bleeding disorders that covers not only von Willebrand, and we have von Willebrand disease page as well, with pretty much all materials and tools that have been mentioned today by different speakers. Thank you so much. So we need to go back to the slide, which was before recombinant versus tranexamic acid. So it was like 7 slides, I think, around before. If you go back.
Oh, that was it, I think.
No.
Yes, I think it was. So the question was actually the percentage change reflects change in PBAC score. So I guess it's one with that score.
This one?
I think so.
Oh, I think it was further on.
Are there any questions?
So it was a question from Kala, if I pronounce correctly, if she's still here, and she can probably, yes, she's still here. So if you can probably comment on this, Kala, is it this slide that you were asking us about? Okay, she's not replying. Then I will use an opportunity meanwhile to ask another question, because as I said, we're really running out of time. So I received one anonymous question, which I would like to address to clinicians, I believe. Can a polyp disappear with no intervention? Because some aged female patients, they shared that sometimes pieces of uterus that were supposed to shed during period or clots may look like polyps under the ultrasound. So can it be that, or it can just disappear itself?
What can disappear by itself?
Polyps.
Polyp.
Polyps? No, I don't
Polyps.
think so. No, just maybe with very heavy hormonal treatment sometimes, but that's the domain of the gynecologist.
No.
Okay, thank you. Then there was a question. There was a question here to Dr. Karin. What time of the months would be best for measuring ferritin iron levels, before, during, or after menstruation?
Anytime. It doesn't matter. You'll have the iron deficiency. That's not something. If you are iron deficient and you don't take extra iron, it will just worsen over time.
Thank you so much. I think there are plenty of other comments which actually are not questions, but just thanks to all different speakers. And there was one topic that actually triggered quite some discussion in the EHC Willebrand Disease Committee chat. Natalie mentioned toilet pass for girls in schools, and we had a brief discussion with patients in the chat, because of course we have patients from different countries. And the question that I personally had, and I asked members of the committee, was whose responsibility is it actually to make sure that a kid in a class doesn't need to explain to a teacher or to speak out loud about the issues that she has, and she needs to go out. And Cathy, I would like actually to ask you and your opinion on this as a mom.
As a mom, I was providing toilet passes for my girls, both of them, myself, because it wasn't at school, and I noticed that it was a big problem, because every time they are raising their hands, can I go to the toilet? It was always, no, you have to wait. Or no, I also have a daughter and she's also menstruating, so I know the drill. And then I was like, no, you don't. She has to go to the toilet. So I made passes of my own. And I think it's, I'm not sure who's responsible for it, but I think as a parent, I was educating the teacher about it, and they worked along with it. So I was making them for myself. But I think at the end, it should be something for the government or something for the hospital to lead the way, or to help provide those things, because it can really make a difference.
Thank you, Cathy. And Beatrice is raising her hand.
Yeah, I just wanted to say that we've done letters for schools, for teenagers going to school. We've done letters for the pupil or the family to give to the teachers so that they can go out. But it doesn't always work because, you know, you give it to one teacher, and in secondary schools there's a lot of teachers, but we try to provide letters. You know, if they say, oh, you know, we know what menstruation is like, it's like, well, this girl, you know, needs to go when she needs to go. So that does work sometimes, not always. A medical letter.
Yeah, we also have medical letters in the Netherlands. But like you said, when you give them to the teachers, you have to hope that at least one teacher is going to read it and do something with it. But most of the time, I don't think they read it at all. So
we sometimes involve social workers. So our social worker can contact school, and then there should be a mentor for every child, especially if there's a medical problem with the child, or psychological problem, anything. So that works, yeah, because then the whole team is informed.
That's nice. Thank you so much. Are there any other questions? Probably someone wants to raise a hand, because I don't see any other questions in the chat. So unless... Yes.
I just wanted to say that in Ireland we have a long-term illness card, which allows people, there are certain defined conditions that you can get free medication with. Haemophilia is one of them, but von Willebrand disease isn't. So if you're a boy with haemophilia, you can get certain medications free. So we're trying to advocate in Ireland for von Willebrand disease and other bleeding disorders to be allowed to have the same rights as people with haemophilia. Because one woman told me she couldn't afford to buy the pill, the contraceptive pill for her daughter. She just couldn't afford to do it. And she because the daughter had von Willebrand disease rather than haemophilia, there was no way of the government providing that for free. And they've just started to provide in Ireland free contraception for people from the age of 17. But if you start your periods at, you know, at 10 or 9 or 8, now maybe you wouldn't go that low with contraception. The contraceptive hormonal pill for periods, it's not free for teenagers. So they're only using it for its contraceptive purposes rather than its treatment purposes. So there's some kind of funny thinking going on sometimes about, you know, about women and periods and contraception. Do you know that for medical use, it's not available until 17? It's just bizarre. I find it bizarre.
Yes, this is a kind of policy, sorry if I jump, that it's common to every disease where one of the treatment envisages is the concentrate, the pills. Yes, also for the many ovaric syndromes, it's the same. So the name of the pills goes with the use, isn't it? I mean, so that's a political reason of reimbursement policy that are behind.
Exactly. And I think that's also why we decided to create this program, because we wanted to truly show the issues that women, not only men as well, of course. I mean, this webinar is specifically about women, that's why I'm mentioning women here. But of course, we know that actually von Willebrand affects equally men and women. So about people with von Willebrand that they face in their everyday life. And today we cover this topic about girls with von Willebrand and their issues. And I truly hope that our effort will be rewarded in this or that way, that we can educate people about differences and about challenges. And I will use this opportunity, since I'm talking now, to thank the speakers on behalf of the EHC and on behalf of the EHC von Willebrand Disease Committee for finding time, for joining our efforts, and thank you so much.
Thank you. Thank you very much. This is really appreciated. Thank you.
Bye-bye. Bye-bye.